So what we're going to talk about now is a little bit about catheter-related bloodstream infections. It's one of these things that kill cancer patients, among other things. First, I want to make an introduction, talk a little bit about the problem. Later on, I will get into more details this afternoon about how to prevent them and all the difficulties we have with catheterization, the type of devices that we use, etc., etc. When we talk about infections, we need to talk about sepsis. As you can see here in this graph, the incidence of sepsis has been increasing over the last few years. In part is because we have become much better at identifying the problem. In part is because we have become very aggressive. We are doing big surgeries. We are putting a lot of catheters in patients. In this data from the year 2000, we can see that there is an annual increase about 8.7% with about 750,000 cases per year or more. Of course, the economical impact of these infections is tremendous. If you look at the data coming from Europe, about $7.6 billion per year in the year 2000. At the same time, in the United States was more than double, with 40% of these expenditures in the ICU. And at the time, we used to say that sepsis killed about the amount of people that fly in 3 jumbo planes every day, but no one was paying much attention. So the incidence of catheter-related bloodstream infections, which is part of the sepsis problem, has been reported to be as low as 3% and as high as 16%, with 2 to 30 episodes per 1,000 catheter days. And it depends on what type of hospital you are, in what country you are, what type of measures you have in place, etc. So 19% of all the ICU infections are related to the use of these devices. 87% of the patients that have bloodstream infections have a central catheter in place, with a mortality that has been attributed to this problem about 25%. So 1 in 4 patients with these infections will die from it. Looking at the year 2002, a publication in the United States showing that about 1.7 million people had infections during that year in the United States, including pediatric and adult patients in the ICU and outside the ICU, with about 100,000 patients that die from it. The second cause was, as you can see here, infections from bloodstream nature. One of the problems that we have with these catheters is that it increase our length of stay, and not only our morbidity, mortality, cost, etc. And the CVC are used these days in more than 50% of the patients in the hospital. In our hospital, probably close to 90% of the patients have a central line in place because of the chemotherapy, etc. And with a range of attributed mortality as low as 10% and as high as 35%, and an economical burden up to $56,000 per survivor. So when we look at these devices and how we actually allow these infections to happen, you can see that there are multiple mechanisms, starting from the hubs, the skin, the infusates that we use in the patients, the skin flora, contaminated infusates, etc., and the host factors, the severity of illness, colonization of the skin. And you will see that as a patient comes to the hospital and stays longer, the patients develop more serious infections with multi-drug resistant organisms. And the longer they stay, the worse the problem is. One of the problems that have been very well described in the laboratory is the biofilm formation. As you can see here, a few bacteria get attached to the device, to the surface of the device, and start to create colonies. And these colonies grow into citadels, and these citadels start to break apart and start to embolize. These are important because as we talk about colonization, we don't give much importance to colonization. But if you look at data even from nasogastric tube placements, when you put a nasogastric tube in place, something so innocuous. 30 minutes after the insertion of these catheters, they are already colonized. And colonization is associated with infections. If a catheter is colonized, there is a high likelihood of developing an infection. The exit site infections, well, these are easy to diagnose. Tunnel infections as well, because you can do it by palpating the area. But the catheter bloodstream infections are much more difficult to identify. Sometimes we don't know that the patients have it and miss the opportunity to fix the problem at early stages by removing the catheter early and not treating the patients appropriately. So these are some of the definitions that the Centers for Disease Control have used in the past. Unfortunately, they keep changing the definitions and confusing us in what we do surveilling for these infections. So this is not really a definition that we use clinically, but for surveillance purposes. And the importance of the surveillance is that we have a number that we can track and then associate with the interventions that we put in place to fix the problem. So we need to have a steady number and clear definition. If we keep changing the definition, we keep changing the rules of the game, it's very difficult to track the impact of what we do. So this is the catheter bloodstream infection definition, absence of other source of infections, the same organism in culture from percutaneous blood cultures, and respectively a semi-quantitative catheter segment culture, a catheter hub segment, or a culture from the infusate. However, now we are using a new definition in the United States. We're using the CLABSI. So the previous was catheter-related bloodstream infections. This is central line associated bloodstream infections. What is the difference? Well, the difference is that basically any patient that has a catheter in place and has a positive bloodstream infection or bacteremia, etc., or the patient is suspected for a bloodstream infection, if the patient has a catheter, we blame the catheter, regardless if it's due to translocation of bacteria from the gut, pancreatitis, or any other type of bacteremia, even if it's from a pneumonia. So for us in the institution in MD Anderson, it's a serious problem because we have a lot of patients with mucositis. All the patients that you have probably have similar problems. And this overestimates the actual rates. So the risk factors for catheter-related bloodstream infections, and I want to continue with this terminology because, in my opinion, it's a little bit closer to what we do in clinical arena, is the lack of strict aseptic measures during the insertion. So 6-fold reduction if implemented appropriate aseptic measures. Experience of the operator is not the same to have a student or a resident putting a central line than to put an expert operator. 8-fold reduction with more experience. The internal jugular catheterization has been associated with a higher incidence of infections. In my opinion, is because those catheters used to be placed with very poor aseptic techniques. The care of the skin with chlorhexidine 2%, which is clearly identified today as a factor to improve the outcomes, with a 4-fold reduction by using chlorhexidine instead of betadine or any other solutions. Personal practices, the number of manipulations, use of needless infusions, the number of ports. The more ports you have, the worse. The more you manipulate the lines, the worse. The more days the line is in place, the worse. So every time you see a central line in place, you need to ask yourself, does this patient need the central line? Can I use an alternative for the central line? The duration of the catheter in place for more than 3 days is 3.3% per day increased risk. So more than 3 days, you have very highly significant association. The colonization at the site, severity of illness, the sicker the patient, the worse. Type of catheters inserted, whether you use an antibiotic-coated catheter, an antiseptic-coated catheter, all these things have an impact in the rates of infections that you are going to see in your units. Transparent dressings have been associated in the past, although recent analysis didn't show the correlation. The most frequent bacteria isolated, you can see depending on the type of catheter, the place where you are, the type of patient, but in general, this is the classic correlation of bacteria and association in TPN, Candida and Staphylococcus, in tunnel catheters, Corynebacterium, Enterococcus, etc. To make the clinical diagnosis, a probable diagnosis will be if you have a positive culture and clinical signs of sepsis. A more definitive diagnosis will be if you don't have any other source of infection and you have a clinical or quantitative microbiologic data implicating the catheter as the source of infection. There are many ways to do cultures and look at the diagnosis from the laboratory point of view. You have the comparative quantitative blood cultures, differential time to positivity, intranominal brush, acridine orange leukocyte cytospin. For example, if you look at time to positivity, there are many studies that have been showing the sensitivity and specificity of this technique. Basically, what you do is you send two cultures, and one from the central line, one from the peripheral vein blood, and if the catheter blood, the blood that was removed from the catheter becomes positive about 2 hours before the other blood, you know that it's the catheter, the culprit. We use it in our institution, but you need to have that technique in place in your lab. In the meta-analysis, the latest meta-analysis published in 2005 showed that pair qualitative blood cultures is the most accurate method, and that's what we also use. Again, one sample from the central line, one sample from periphery, and then you follow the results. Once you have a suspicion, you try to confirm the diagnosis. These are the laboratory indicators before the CVC is removed, and the clinical signs such as inflammation, pus, etc. The quantitative is colony forming units from the CVC, with more than 5-fold than the peripheral blood cultures, and the qualitative CVC blood culture becomes positive at least 2 hours before. Now, we have another problem, and is that when we take blood cultures, if you have a triple lumen catheter, you know, a catheter with 3 lumens, you may be sampling the port that is not infected. So if you see this study here published by Dobbins, 40% of CVCs associated with catheter-related bloodstream infections found that only 1 lumen was significantly colonized. So you may miss completely the diagnosis. If you send peripheral blood and a central line catheter blood sample, both one could be positive from, you know, but at the peripheral and the catheter, but they may be responding at the same time, be positive at the same time, and then you don't think the catheter is the culprit. So that is a serious problem that we have, and we cannot fix it because sampling the 3 ports will require too much blood removal from the patients. And we are already removing almost 1 unit of blood a day with all these samplings that we are doing in the units. The management considerations include the extent of the infection, whether it's local or systemic, what type of microorganisms are causing the infections, the type of catheter, whether it is a surgical implantable catheter, percutaneous CVCs, is a PICC line or whatever, and the host factors, whether the patient has neutropenia and thrombocytopenia, etc. I have worked in many ICUs over my life, mostly trauma, military units, pulmonary centers, etc. But when I came to MD Anderson 12 years ago, I started to see things that I never see in my life, like putting a central line in a patient with 0 platelets. If you go to a trauma center, no one will really be thinking about putting a central line in a catheter with no platelets or any other type of units. And the most interesting thing is that many of these patients don't even bleed when you puncture them. I put big catheters. But some patients, like myelodysplastic syndrome patients, have a very high tendency to bleed. It doesn't matter what is the platelet count. So in these patients, it's very difficult to take decisions to remove catheters, because if a patient has a catheter in the subclavian vein and you think that the catheter is infected, you cannot remove it, because by removing you can cause an hemothorax and kill the patient. So that presents challenging decisions in the clinical arena. But the catheters in general are recommended to be removed. If you see the CVC removal improved response, look at these studies here showing that the patients that had the catheter removal have much better outcomes. In patients with candidemias, the same thing. These are studies supporting the removal of the catheter and the better response. Only one study of the ones that I know didn't show any difference. This study by Raad, who is the chair of the Department of Infectious Diseases in our institution, and you can see that there is a significant difference in the patients that have the catheters removed versus those that didn't. Now, there is a tendency to salvage the catheters, because of the reasons I mentioned, the thrombocytopenias, because some of these catheters are implanted, and we don't want to, expose the patient to a surgical procedure to remove the catheters. So there are techniques that have been developed, like, for example, exchanging the catheters for a catheter that is antibiotic coated. At the beginning, we were really concerned because we thought that if you have an infected catheter, by replacing the catheter, you basically are pushing more bacteria, creating more bacteremia, and potentially having a patient with worse outcome. But we have started to see is that actually, if the patients are stable enough to tolerate an exchange of the catheter, these patients are doing much better. So these are this is from the study of Shaftari in cancer in 2010, showing the difference between those catheters that were exchanged with those that were removed. And you can see significant difference in the relapse or infection-related death and mechanical failure. The same time is here, exchange group, 95% overall response versus 76% in those that have only the catheter removed. So we think that is maybe the effect of the antibiotic and the tract that may have been infected. So those patients that may have a tract infected, that the infection started in the skin, or the catheter was externally colonized, because the catheter could be colonized externally or internally, and we will discuss this in the afternoon when we'll talk a little bit more about bloodstream infections, then that could be a factor that plays in their favors. Mechanical failure, pneumothorax, or unsuccessful attempts, when you are trying to exchange the catheter, you're going to have much less complications than if you are removing a catheter and putting a new one. So you need to look for a new site. And in attempting a new site, you may have an hematoma, hemothorax, pneumothorax, and other complications. These are in vitro. So when you look at the catheters that were exchanged uncoated versus those that were coated with chlorhexidine and the minosin rifampin, you see that there is no growth in the minosin rifampin. Minosin rifampin catheters have been a tremendous success, and one of the best ways to reduce the infection rates associated with these catheters. Again, following the same study, they removed catheters within 7 days, and the results in the defervescence of fever, etc. This is a study published in the New England Journal of Medicine showing basically two things here. What I want to point out is, one, the patients that have sepsis, septic shock, you don't talk about rewiring any catheter. You just remove the catheter. Only those patients that actually are stable enough, you consider rewiring the catheter. These are from the Infectious Diseases Society of North America, Guidelines for Intravascular Catheter-Related Infections, published in 2009. They recommend to do a guide wire exchange with an antibiotic-coated catheter when it's possible. Almost to finish here, the catheter-related bloodstream infections with non-tunnel removable catheters in non-complicated infections. So you could consider keeping the catheter if it's coagulase negative staph, the culprit. But if it's Staph aureus, Candida, or other organisms, you remove and treat for 14 days, do transesophageal echo or transthoracic echo, depending the capabilities to treat the patient. In complicated, you treat with antibiotics for at least 14 days, remove the catheters as well, and in osteomyelitis, endocarditis, or septic thrombosis, you treat the patients for 4 to 6 weeks. Okay. This afternoon, we'll talk about ventilator-associated pneumonia and catheter-related bloodstream infections. And I will expand in all the type of devices that we actually use, antibiotic-coated, etc. We have moved now to more peripherally inserted catheters, particularly because of the challenge that we have with thrombocytopenia and respiratory failure.